been using BOSENTAN for pulmonary hypertension for the past 3 to 6 months now, ever since it has been licensed for use in India, and with very good results for those patients who really require it on a clinical basis. We have been all the time suspecting pulmonary hypertension in patients with a history of pulmonary thromboembolism, patients who have recurrent pulmonary thromboembolic hypertension, and also in those patients who have mitral stenosis with their pulmonary hypertension, and also those patients with COPD. We as chest physicians see a large number of patients with COPD, and about 20% of them certainly tend to have, or close to about 18 to 20% have associated pulmonary hypertension. And we clinically suspect it when, despite optimal treatment for their COPD or their chronic airflow limitation, their symptoms of exertion, breathlessness do not get optimally controlled. The various diagnostic activities which we normally undertake, diagnostic tests to identify and assess the pulmonary hypertension, are firstly by a clinical examination, where clinically we start suspecting pulmonary hypertension when we have a loud P2 and when we have a split second heart sound. Secondly, when the patient comes to us with right heart failure, so it's not uncommon to see these patients with associated pulmonary hypertension. So in such a scenario, we would like to get a simple chest X-ray done, which classically would show upper lobe venous diversion, highly suggestive of pulmonary hypertension, along with RA-RB dilatation, which can be picked up on a good digital chest X-ray as well. This is further confirmed by doing an echocardiogram and a 6-minute walk test. Echocardiogram invariably clinches the diagnosis, and we pick up majority of the patients in our clinic when we suspect clinically by asking them to undergo an echocardiogram. 6-minute walk test is of particular use in our patients for monitoring while they are on treatment to assess the degree of therapeutic response to our treatment with either low-dose sildenafil or low-dose sildenafil and BOSENTAN. In such a combination when we use, then we normally try to assess the therapeutic response, and in our experience we have seen that over a period of time, large number of patients after initial 6 weeks to 12 weeks show significant improvement in their 6 minutes walking distance. As regards the safety and efficacy of this molecule is concerned, the only issue is about the hepatotoxicity. So to be on the cautious side, we start with low doses and then try to build it up to 62.5 mg in a BD dose, and then maybe increase it to a higher dose of one morning and one evening if the patient starts showing signs of improvement. But as I said, most importantly, the therapeutic response needs to be assessed from the point of view of our clinical judgment and from the point of view of our monitoring 6 minutes walk test. As regards the side effects are concerned, we tend to monitor the liver function every 3 weeks, and a lot of patients do have at higher doses hepatotoxicity, particularly elevated transaminases, and that is one of the worries with us, and therefore we tend to err on a cautious side and start them with low doses. We also see large number of patients with a combination of low-dose sildenafil and BOSENTAN, and as you are aware, majority of these patients again may have increased risk of hepatotoxicity, and therefore there is a good case for doing a regular monitoring of the liver function test. We have hardly had any other problems with BOSENTAN, except of course for 1 or 2 patients who have had drug hypersensitivity with skin rashes, nausea and vomiting, but otherwise by and large majority of the patients tend to accept in a reasonable way the regular usage of BOSENTAN. Thank you.
Thank you, sir.